minor stroke are an emergency is precisely that the recurrent strokes are preventable. Not only is the prognosis bad, but it's preventable. And that was shown in the early days in two studies, one in Oxfordshire, the Express study, and one in Paris, Pierre Amarenko's SOS-TIA study. And both of these studies showed that if you take patients with TIA and minor stroke and just give them the current existing treatments immediately, you dramatically reduce the early risk of recurrent stroke by about 80%. And this was just by giving patients aspirin, clopidogrel in higher risk cases, a statin, and blood pressure lowering. Using existing treatments, you can take these patients and prevent nearly all of these early recurrent strokes. And it just shows how exquisitely preventable this condition is. You can take these very high risk patients and switch them to a lower risk state just by using standard treatments and doing it immediately. And it turned out, in fact, that the most active ingredient in that cocktail is probably aspirin. And Shelagh will say much more about acute treatment. But when we went back to the old secondary prevention trials that had already been done of aspirin versus placebo in long-term secondary prevention and looked at the time course of that effect in these randomized trials, it turned out that nearly all the benefit of aspirin versus control was in the first few weeks of the trials. So in the acute phase, where aspirin, even in these randomized studies, did reduce the risk of recurrent stroke by 50-60%. And if you look at the different studies involved, then it's a remarkably consistent treatment effect. So one of the most impressive treatment effects in medicine. And interestingly, aspirin also reduced the severity of the early recurrent strokes versus placebo. And Shelagh will say much more about the nuances of treatment shortly. But given that we have such an exquisitely treatable condition that's high risk without treatment, of course, it's imperative that we get the diagnosis right. And this area of what's a TIA and what isn't has over the years almost been an evidence-free zone. We've all bought into something called the NINS criteria, which was the expert consensus statement from the 1970s by eminent stroke neurologists and stroke physicians of that time, who just came together and used their clinical experience to say what they thought a TIA was, and came up with the NINS criteria for classic TIA. And you're all familiar with these. They're in the guidelines, they're in the textbooks. So motor weakness, dysphasia, sensory loss involving two or more body segments, hemianopia, quadrantanopia, amaurosis fugax, and then the posterior circulation type symptoms, as long as they're associated with some other more TIA-like event, so not isolated syndromes. But of course, that leaves a large number of patients who have what you might call non-consensus TIAs, where the NINS statement said, in fact, these weren't TIAs. So isolated vertigo, isolated unsteadiness, isolated double vision, isolated dysarthria, bilateral decreased vision, and single segment sensory loss. And in fact, these account for about 50% of all TIAs. And clinical practice varies because the textbooks say they're not TIAs. So in many cases, patients are reassured that it's some sort of benign condition and not treated. And we became suspicious about this many years ago when we looked at posterior circulation strokes and looked at the timing of transient symptoms prior to the stroke. And if you look at carotid territory strokes, then most of these transient symptoms are NINS TIAs rather than TNAs. But in the posterior circulation strokes, there was the same time course of preceding symptoms, but most of them didn't qualify as TIAs. They were these isolated brainstem symptoms. And so we looked prospectively. Maria Tuna did this big study looking prospectively at these non-consensus TIAs and comparing the prognosis with the more classic NINS TIAs and the classic minor strokes, and found, in fact, over 10 years follow-up that the non-consensus TIAs, the isolated brainstem symptoms, have just the same risk of major vascular events and pretty much the same risk of recurrent stroke. The risk from time of seeking medical attention is somewhat lower in the non-consensus TIAs because they tend to prevent later. So you miss the early risk. They present after they've had a major stroke, which was preceded by a TIA. But in fact, if you look at those cases that present on the same day as the TIA, then the classic NINS TIAs aren't really any higher risk than the non-NINS excluded TIAs. So in fact, they're probably all TIAs. And even if you look at the NINS TIAs, the prognosis varies, of course, as you all know. Motor TIAs are higher risk than non-motor TIAs and than amaurosis fugax. And the non-consensus TIAs are somewhat intermediate. They're about the same as non-motor NINS TIAs, but they're higher risk than amaurosis fugax. We don't really have numbers to differentiate between the different syndromes, but clearly these isolated brainstem syndromes are mostly TIAs if you can't come up with a clear-cut alternative diagnosis. So this paper was looking at focal negative non-progressive symptoms, so more classical TIA symptoms. There's a follow-up paper coming out looking at non-focal positive or progressive symptoms. And the results are actually surprisingly similar. Most of those turn out to have a high vascular risk as well. Transient confusion in elderly patients is a TIA until proven otherwise if you can't find an alternative diagnosis. So we need to broaden the diagnostic criteria for TIA, I think, and we probably need another set of expert consensus to do that. In terms of investigation, just starting off with these non-consensus syndromes, of course, DWI, diffusion-weighted imaging, is incredibly helpful in telling you whether you're dealing with an ischemic event or not. As you're aware, in the posterior circulation type events, DWI is less sensitive, probably only about 20% of posterior circulation. TIAs have a positive DWI, but sometimes they do, and you can get obviously cerebellar lesions causing transient vertigo or transient ataxia. Transient diplopia is frequently DWI positive, usually small thalamic lesions and bilateral visual disturbance as well. So DWI is probably the most useful diagnostic tool, and it's much more accurate than clinical ability in giving a vascular territory as well, and identifying patients with multiple lesions due to cardioembolic source and giving characteristic patterns in patients with large artery, carotid or MCA stenosis. I'm sure you're all familiar with this. And DWI is also a prognostic value. This is some early data from when we first started doing DWI in the 2000s, showing that patients with a DWI lesion are much higher risk for 7-day recurrent stroke than patients without infarction. The risk scores still seem to work whether you're DWI positive or DWI negative, but DWI itself predicts rather more powerfully than the clinical information. And interestingly, if you look at long-term follow-up, DWI positive TIAs have a higher long-term risk of recurrent stroke than DWI negative events. So there's also useful long-term prognostic information. And obviously the minor strokes tend to be more DWI positive than the TIAs, and that increases with the NIHSS score as you'd expect. So what other investigations in addition to brain imaging? Carotid imaging is obviously important, as you know, and that needs to be done quickly after a TIA or minor stroke. When we looked many years ago at the pooled data from the old trials of endarterectomy versus medical treatment after TIA and minor stroke, the earlier patients got in after the event and had their surgery, the greater the absolute benefit, with numbers needed to treat of only 33% absolute risk reduction in severe stenosis treated early, and that benefit fell with time. In those days, in the UK and many other countries, these patients were being imaged up to 3 months after a TIA or minor stroke when the benefit was tiny. So carotid imaging is obviously needed urgently. And we should probably be imaging patients for intracranial stenosis and in posterior circulation events for vertebral artery stenosis as well. And even in a Caucasian population, such as in the UK, when you do intracranial and posterior circulation imaging in all patients, you find that posterior circulation stenosis and intracranial stenosis is actually at least as common as carotid bifurcation stenosis in all age groups. And the older patients who perhaps tend to get imaged less frequently, of course, have the highest rates of disease. So the sort of old-fashioned attitude that the high-tech investigations ought to be kept back for young strokes makes no sense. The older patients have much more pathology. And of course, patients with large artery intracranial stenosis certainly have a higher risk of recurrent stroke than patients without intracranial stenosis. And there are therapeutic implications of finding intracranial stenosis, even if we don't necessarily stent these patients following the SAMPRAS results. In terms of posterior circulation stenosis, there was some evidence in this patient group from the VIS trial that we did a few years ago with Hugh Marcus that stenting is perhaps more effective than medical treatment in patients with vertebral origin stenosis. And we're now doing the VIS2 trial to look at this particular group in more detail with big enough numbers to try and get a reliable result. So it's worth knowing about posterior circulation disease as well for various reasons. Interestingly, if you look at the nature of the TIA, you won't be surprised to see that the non-consensus TIAs with posterior circulation symptoms are more likely to have posterior circulation stenosis than anterior circulation stenosis, whereas the classic TIAs, which are mainly carotid, are more likely to have carotid and MCA stenosis than posterior circulation stenosis. So more evidence that these monosymptomatic posterior circulation events are genuinely TIAs. Of course, we do ECGs and we look for AF in patients with TIA, but we should and minor stroke. We should probably be doing routine prolonged monitoring R tests at least for 5 days, and we find a reasonable, at least in our minor stroke and TIA population, hit rate. About 10 to 15% of patients have something on their R test which looks like AF. Interestingly, if you split it into AF less than 2 minutes, which is mainly 5 to 10 seconds in most patients, to AF more than 2 minutes, which is often 10, 15, 20 minutes, 2 hours, then prognostically there seems to be a difference. The patients with AF lasting more than 2 minutes have a much higher risk of recurrence than those with short, transient episodes of AF. And this group is more common in minor strokes than TIAs, but in cryptogenic TIAs, you find about 5% of patients have episodes of AF lasting longer than 2 minutes. So probably a sufficient hit rate to be worth doing. PFO screening, we do that in all the TIAs and minor strokes. Now, as you know, TIAs didn't get into several of the trials of PFO closure, and most of the guidelines only recommend screening in patients with stroke or DWI positive TIAs, but I think you can make a good case for screening in anybody with a good history of TIA, particularly if there are markers that a PFO might be involved. And I think PFO closure for TIA is not unreasonable in clear-cut cases. The most important, finally, last but not least, is diagnosis of hypertension. And one of the problems we have in clinical practice, and the guidelines at the moment still focus on clinic BP, is that clinic BP is almost useless in TIAs and minor strokes. These are some old data from old cohorts, the European Carotid Surgery trial, the UK TIA trial, and the Dutch TIA trial, showing that if you plot one clinic blood pressure against the next clinic blood pressure, it's almost uncorrelated. It's almost a snowstorm. And it's because blood pressure is so variable in these TIA patients that a one-off clinic measurement is almost meaningless. And we find that if you do home telemetric blood pressure monitoring, which we do now in our patients, everyone goes home and measures their blood pressures 3 times a day, and we monitor it centrally, and it's all over the place in the majority of patients. So a one-off blood pressure isn't enough to really diagnose normotension or hypotension in TIA patients. We've just finished a study of over 1,500 patients with TIA and minor stroke, where we've compared the predictive value of baseline clinic blood pressure with 1 day of home blood pressure, so 9 measurements of blood pressure at home for the day after the clinic, or 3 days. And the predictive value for recurrent vascular events is much better for home blood pressure than clinic blood pressure at baseline. And it's the same at 1 month, whether you use an ABPM or 3 days of home blood pressure at 1 month, it predicts better than clinic blood pressure. So we probably ought to move from just measuring a quick blood pressure in clinic to investigating and diagnosing hypertension properly in future. So when you treat TIA and minor stroke more aggressively, and this is Pierre Amarenko's data from the TIA registry, the risk of recurrent stroke is now much lower after the acute phase once patients get into the registries, but it's still high, and it's still in some ways related to the risk scores. So there is still residual risk to treat, which Shelagh going to talk about shortly. And there's also a risk of dementia, which we mustn't forget. In TIAs and minor strokes, the dementia risk after a stroke is much higher, as you'd imagine, after a major stroke. But even in NIHS 3 to 5, NIHS less than 3, and in TIAs, the long-term risk of dementia is still quite high. And the risk of cognitive impairment is much, much higher in these patients. This is just full-blown dementia. So again, there's work to be done to reduce that. So in terms of take-home messages, I think TIAs are currently underdiagnosed and therefore undertreated. We need to spread the net much wider. An elderly lady that comes into the ED with sudden onset confusion and 1+ of protein in the urine is not a UTI, it's usually a TIA. And really, I think anyone with transient, unaccustomed neurological symptoms, if they're older or they've got vascular risk factors, should be considered as potential TIAs, unless we can come up with an other credible diagnosis based on something more than 1+ of protein in the urine. Early recurrent stroke after TIA should be regarded as preventable. It should be a never event, in the same way as maternal death, as regarded by the obstetricians. These are exquisitely preventable. Even aspirin alone is highly effective. Patients with TIA and minor stroke deserve urgent and detailed investigation, no matter how old they are. The older they are, the far greater the yield of investigations is. So we should be investigating patients irrespective of age. So I'll stop there, and we'll now hear about how best to treat these patients.
Thank you very much, Professor Rothwell. We are going to come back at the end for the questions. I mean, the only one comment, though, I want to make, I was watching these slides with the home blood pressure measurement as we're sitting here with virtual conferencing, and I have a virtual clinic this afternoon. And I got to say that's incredibly reassuring, because one of the biggest things that I thought was a detriment to virtual care for our stroke patients was the inability to measure their blood pressure when they come in. But now we're seeing that actually maybe this is the better way, is to have them measure it at home. Is far more superior. So that's very reassuring, sir. So I'm going to just move to Dr. Coutts next, and then we're going to come back and do some questions and answers. So it's again a great pleasure for me to introduce my mentor, Professor Coutts from Calgary. Professor Coutts obtained her medical degree in Edinburgh, but went to Calgary, Canada, to work under Dr. Alistair Buchan for her stroke fellowship. And fortunate for both Calgary and Canada, she decided to stay. Since she's been in Calgary, she's done an immense body of work in the field of TIA and minor stroke, You may be familiar with the VISION and the DOUBT and the CATCH studies, which were quite landmark. And more recently, Tempo 1, of course, a dose-finding study for TNK, and the ongoing Tempo 2, which is a huge international effort led by Professor Coutts, looking at tenecteplase for minor stroke. She has won many awards for her work, including the Secret New Investigator Award from the American Stroke Association and the Pessin Award from the American Academy of Neurology. So it's always an absolute pleasure to introduce my friend and my mentor and former fellowship co-supervisor, Dr. Coutts. We can see your slides, Sheila, but you are on mute.
Okay, thanks, Dar. I'm going to talk about the treatment of TIA, and I'm going to give you a bit of some data, what that means for me and my everyday practice, and some sort of very much editorialization, because I think, you know, the data is there for many of these things, but how you use it in real life is, you know, is different than a trial. So I'll try and talk about that a bit. I'm obviously in Calgary, and as Dara has mentioned, I am Scottish originally, and I am, there we go. Okay, so my disclosures are much like Peter's or grant funding, although I do get tenecteplase provided by Boehringer for my Tempo 2 trial. So I'm going to review the treatment. Just to reiterate something that Peter said as well, which is that I think the crux of what we do in stroke is imaging. And when I talk about imaging, I'm always talking about vascular imaging as well. We are simple people, I think, in the field of neurology as stroke neurologists, and we're essentially plumbers. It's all about the blood vessels for the most part. And I don't think you can look after stroke patients without being able to look at their vascular imaging. So I think from a practical standpoint, every single patient who comes in with transient neurological or persistent neurological deficits needs brain imaging urgently. It can be either CT or MRI. Certainly in North America, CT is the workhorse of the emergency department. We have 2 scanners that literally run 24/7 in the emerge. You always need to rule out a structural lesion, and if you happen to be in emerge, there are a lot of things that have transient events that you don't get consulted on because the subdurals, the tumors, etc., have already been ruled out. MRI is clearly more sensitive for ischemia, and I will never be unhappy that I got an MRI scan. But CT is much more practical in that emergency or the urgent figuring out what's going on. All of stroke care is about finding out why something happened. And although there are recipes that we'll give you in terms of guideline-based care, I think the thing to always move your practice from being average to being excellent is to think about the individual patient and why it happened, rather than just a recipe of patient needs to be on aspirin, a statin, and that sort of thing. Vascular imaging, and I will say this time and time again, is absolutely everything. Carotid Doppler is acceptable, but it is substandard compared to CTA for the reasons Peter even mentioned there, which is that intracranial imaging is important, even in Caucasians. We used to have this idea that intracranial atherosclerosis was a disease of non-whites. That doesn't appear to be the case, and I'm surprised time and time again of the things that I pick up on CT angiogram that would never have been picked up by Doppler. And I'll show you an example later in this talk. So this is work that we did in Calgary in the CATCH study a few years ago. And this is MRI and CT. So CTA completed in a minor stroke and TIA population within 24 hours of onset. The red curves are abnormalities that are symptom relevant on a CT angiogram. The blue is basically a normal CT and CTA. And then on the right-hand panel, that's DWI positive versus negative. The interesting thing, if you look at these slides, is a couple of fold. One is the curves separate overnight the first night. And I always say that the single most dangerous time after your minor event is overnight the first night. These are the patients that you put to bed who are talking to you with very minor deficits, and you come back and round them in the morning, and then they're plegic or they're not talking. And we've all had those patients. And it is a horrible feeling. And I like Peter's sort of analogy of maternal death, because really this is what we should be stopping. And so these curves separate overnight the first night, and they don't really separate after that. As you can see, that the bottom line is that CTA negative does not mean you haven't had an ischemic event. It just means your immediate risk is less. And the same is true of DWI positive versus negative. What I do is I use CTA for urgently assessing patients in the emergency department. And what we do is we use it to triage who goes home and who we see urgently in clinic in the next couple of days. MRI scan I find much more helpful, helping me decide if somebody has actually had an event or not. If somebody is 80, they were hemiplegic for 10 minutes and they've got better, an MRI scan most of the time is not going to help me. And so it's, you know, this is what I tend to use in my practice. So what in terms of can we do then if we do this scan? I mean, scans in isolation are not helpful. I'm going to talk about things that happen urgently here, which is going to be antiplatelet therapy. I'm not really going to talk about anticoagulation, and we can talk about it in the question and answer later. My personal view is if you have AFib, you should be anticoagulated quickly. In most minor stroke and TIAs, I would do it immediately if it was a TIA. If they have a vascular occlusion and I'm not sure how big the stroke is, I may wait a couple of days. But it's all going to be urgent. And the DOACs have made this so much more simple than with warfarin. I think some of you may have heard my mother had a stroke a few years ago, and I've been sort of pushing for care in Scotland to be improved that we found at that time. One of the things I did with my mum, though, is I looked at her scans and I was like, she's got to have AFib. And we didn't pick it up on a Holter. And I bought her a Cardia device on Amazon and got very lucky. And I picked up AFib on day 4. And so I think we can do more to identify AFib. Carotid revascularization is key, and I'll talk about that. And Peter has done a lot of work on this area to tell you who to do and when. Everybody needs vascular risk optimization. And I think it's fair to say that because we're so overworked and don't have time to do primary practice sort of work, this is probably an area that could be done better. And I'll touch a little bit on this, but again, we can talk about this in the Q&A if we have time. So dual antiplatelet therapy. To just take a step back is that most patients are going to be on aspirin. The one comment I would make is that I personally in the elderly used to think, oh, well, if I'm not sure, they should just go on an aspirin. My practice has changed a bit with that because what is clear from the Aspirin study and other studies is that aspirin for primary prevention in the healthy elderly is actually harmful. And so just be aware that diagnosis is important, and just putting somebody on aspirin because they're old does not have good evidence base. And so it still is important to have an accurate diagnosis. And I mean, yes, the risk is low of having a GI bleed that's significant. However, you know, if you're an individual patient, having a GI bleed is a problem. So to get into point, you had to have a high risk event. So you needed to either have a minor stroke, so you basically had minor deficits of an NIH3 or less, or you used the ABCD squared score. So that was mostly motor and speech, or prolonged duration. You had to be older than 18 years, but the nice thing about point is that many of these trials are now doing is no upper age limit, because elderly people have events too, and we want to stop their big strokes. You had to be treated within 12 hours of onset. And so they struggled a little bit with recruitment, as 12 hours actually is a short period of time post-symptom onset. As Peter's shown you, many of these patients don't turn up immediately in the emergency department. Important comments were from a practical perspective, there was no isolated numbness, dizziness was not included. And so these posterior circulation events, which are clearly real, they're just not carotid ones, were excluded. you couldn't be planning to do a carotid endarterectomy, and I've not seen the data that actually sort of says how many patients with that sort of large artery disease actually got in, because you didn't need a CTA to be randomized within point. You need to not be AFib. Obviously, some people would be identified as AFib after their emergency department visit. The thing that isn't interesting, and I understand why they did it, but from a practical standpoint, most of us would ignore it, is that you couldn't be on regular NSAID use. And this was a huge problem when we were trying to screen patients for point. There's a lot of people with arthritis, and a lot of people take NSAIDs regularly. And I think I would never use this as a reason to not put somebody on dual antiplatelet therapy. So it was an interesting exclusion. Basically, it was a loading dose of 600 milligrams of clopidogrel on top of aspirin. And then the treatment group got aspirin plus Plavix, and then the control group got placebo for 90 days. So this is essentially the main results of point. This was published in the New England Journal, and this is Clay Johnson was the lead investigator here. You can see that there is a decreased risk for the primary outcome, which is essentially MACE, going from 6.5% to 5%. And then you can see that these are mostly driven by ischemic stroke prevention. There is an increased risk of hemorrhage, with major hemorrhage being statistically significant. What you can see in terms of the results are that you do most of the benefit in terms of stroke prevention is early. And these curves separate quickly. And then you don't really see much ongoing benefit. And so you need to be treating people early. The complications, though, continue to happen. So they start early with the aspirin and Plavix, and then they continue to happen all the way out to 90 days here. So most of the recurrent stroke events prevented were early. Hemorrhagic events do continue to happen throughout the 90 days. They're mostly not intracranial hemorrhage, which has some implications for our practice. It's mostly GI. There's no prevention disability in the point trial, which is interesting, although there's been a sub-paper recently that I was involved with, which does show we prevent some disability, depending how you look at it. What about CHANCE? CHANCE was the Chinese only study that was completed in record time, actually. They were very quick to be able to finish the study, and just showing the machine of when China can push and do things. CHANCE was slightly different, but very similar to point. So treatment was within 24 hours for CHANCE. It was the addition of clopidogrel to aspirin, but clopidogrel was the background. And so it wasn't aspirin monotherapy, it was Plavix monotherapy. And so they had 3 weeks of the dual antiplatelet therapy. The interesting thing in CHANCE was there was no difference in the hemorrhage rates between the two groups, which again sort of triggers this 3 weeks of treatment, which is where the guideline-based care has come for sort of 3 to 4 weeks. This was just published as an abstract at the American meeting just last month. And this was looking at patients who had an MRI within point. And it certainly suggests that if you do not have an infarct on your MRI scan, it questions whether dual antiplatelet therapy should be being used. We haven't seen the full paper, so we need to look into this in more detail. It's a post-hoc analysis and all the issues with that, but it certainly raises the questions of a DWI negative patient and what you should be doing. So in real life, what do? Canadian guidelines are 3 to 4 weeks of dual antiplatelet therapy. That's what we mostly do. In the elderly, I do add pantoprazole on not a lot of evidence base, although there are some trials running that will give us more data on that. But I really want to know what events are we preventing with dual. And you know, if you think mechanistically, you've got to believe that large artery disease is going to be more affected by clopidogrel than sort of a cardioembolic event. But unfortunately, we don't really have that data from point. So what about in real life, the other things? Are you avoiding dual antiplatelet therapy in patients who are taking NSAIDs? I'm not. I would be very careful about adding pantoprazole if they're not already on it. But, you know, I think it's something you need to be careful of and think about. The ABCD squared score was simply to avoid too many minutes in the trial. So I'm not going to use the ABCD squared score to choose who I'm going to treat. I'm going to treat anybody who has a good story for brain ischemia. And actually what happens in practical terms is if your CTA is normal and isn't high risk, you get aspirin Plavix and sent to clinic by our emerge docs. We can always stop the Plavix and or the aspirin when we see them in clinic. I think it's important to remember that even if somebody starts dual antiplatelet therapy, you can stop it. And so just because somebody else has made what you think is a wrong diagnosis is fix it when you see the patient. So I think, you know, the big thing is to treat early and then appropriate when you have all the information available, stop things as needed or keep them going. So what about the biggest thing that we do, I believe, is treating and identifying extracranial carotid artery disease. This is highly, highly treatable. This is a beautiful picture from a CTA. This is what we're looking for. One of the big reasons we're doing CT angiograms. The big thing is it's about 10% of patients. Certainly where I work, it's about that. And it really, that number will depend on how much smoking you have. But at least 40% of the early recurrence. So this is information from a Swedish study. Essentially they looked at sort of 2 time points when they were doing early versus later ENDARTs. And with a median intervention time decreasing from a couple of weeks to 1 week, they've reduced by 10% their complication rates. And obviously there are other things likely involved here, but early is going to be the answer. And what does that mean for me? And what that means is that if you have severe stenosis, so this is NASCET measurements here of 70% to 99%, most patients, if I see them early, are going to be offered revascularization. It's a more nuanced approach in the 50 to 69% range. But I'll show you some data, and certainly if somebody is not a high operative risk and they turn up and see me 2 days after onset, most of the time I'm going to look at intervention for them. Ideally, you do this as soon as possible if they're stable. And so this is nice work. This is a meta-analysis or a figure from Peter's study where they pulled the ENDART trials. And I think the biggest thing for me, what this shows is that we should be doing things early. There is absolutely no doubt that these patients need treated urgently. And how you do this will depend on your institution. For us, that means I have to admit them to hospital most of the time to be able to do it quickly. And it's hard to do as an outpatient. So what I do is, if I see a patient who's in the 50 to 69% stenosis range, and unless they're at very high surgical risk, we're going to go ahead and do an ENDART or stenting, depending on the technical standpoints, if we see the patient early. This again is just from Peter's meta-analysis, just sort of giving you the idea that there was, on the pooled trials that were done previously, that women had less benefit from ENDART. It is interesting that they looked at this as a specific thing within when they did the CREST study, and obviously there was no medical intervention in CREST, but they didn't find any difference in the benefit or complications when they did the recent CREST study. But it is part of the decision-making for me. If a patient is borderline from a surgical risk standpoint, they happen to be female, they happen to have only a 55 or a 60% stenosis, you know, you start to be sort of just adding things up that it makes you not want to do it. The much more difficult group for me is the patient who turns up a month after their onset, who have a 60% stenosis, and what to do is the hard part. And that will always be a discussion between you and the surgical team. So what makes sense? Early as possible. So regular audits, though, by your surgeons need to be to see complication rates I personally try and treat everybody with a 50% that I see early, as long as they're not super high risk. But what do you do if you have to wait a few days? We actually often will give a patient a loading dose of Plavix in the emerge, and that sort of helps you over that first overnight period, as we're getting the surgeons to look at the scans and decide if we're going to do surgery, stenting, or what we're going to do. I don't know how many patients got into point with large artery disease, but I'm interested to know that. And that's for discussion. And clearly the use of a single day of clopidogrel is non-evidence-based and will never be evidence-based, but so far it's certainly been pretty safe and for us. What about small vessel disease? I think this is the last bastion of evidence whatsoever. Does dual antiplatelet work? The problem is that unless you're using acute MRI, making the diagnosis, this is clearly small vessel disease, is going to be wrong 50% of the time. I like to say that neurologists used to be right before we did MRIs. Does anything actually work? We do tend to give people IV fluids. If they're fluctuating, lie them flat. I don't know if it works, but it makes certainly us feel better. Statins, almost everybody should be on a statin if you had an ischemic stroke. There's no good data on knowing exactly when to start, but I tend to start it the first time I see the patient if they're not on it already. My personal choice would be a high dose of a potent statin. And then there's some nice data from Pierre Amarenko, which is one of my favorite papers in the last few years, where they targeted high versus low for cholesterol levels, for LDL levels in patients who had recent ischemic stroke or TIA. And so basically from a non-American numbers, we're talking about targeting less than 1.8 millimoles or the 2.3 to 2.8. Basically, you had to have some evidence of atherosclerosis, either on a extracranial, intracranial circulation or coronary disease. And so just briefly, I would push people to go read the paper if you haven't, because it's one of the nicest papers mechanistically that's happened. And again, was done as an academic driven trial with a lack of, with not large amounts of funding. And so it's phenomenal, the results they got. So this just shows you the top level, just shows the LDL based on target. And then the bottom level is the primary outcome, which is essentially MACE with also some carotid revascularization in there as well. As you can see, this was a long study, up to 8 years of follow-up, but much lower event rates if you targeted lower LDL levels. And so again, showing that we probably should be looking at this carefully. So this is just from a review we did a few years ago, just suggesting what is higher risk. And I'll just direct you to looking at this. This was published in Continuum from the American Academy of Neurology in the TIA chapter, and just gives you a good idea of what is the lower risk versus high. So what are we heading for ideal care? Rapid access, same day clinics or same day in the emergency department. Doesn't really matter where you see them. My personal preference is going to be a CTA to look at the arteries, MRI to help me rule in ischemia in patients who are it's more unclear. Clearly aspirin, some people are going to get Plavix as well. Rapid access to carotid indart, immediate use of anticoagulants for AFib. Timing of statins, I would just start it early, go hard, get it low. BP management is going to be more of a slightly delayed. I love home monitoring. I tell everybody to buy a home blood pressure cuff. And we clearly need novel treatments in these patients. I don't care where you do it, and it's set up your own system that works for you. With imaging, though, it's often easier done in the emergency department or right beside it. And so we use CT, CTA to screen for high risk, and then MRI for lower risk patients, usually from a clinic setting. This is just an example of why I don't like CT head and carotid Doppler. This was a 32-year-old guy. He had transient tinnitus in his right ear and then 10 minutes of right-sided weakness, symptoms completely back to normal. He's absolutely healthy otherwise. And he has a partial occlusion, like a thrombus sitting at the top of his basilar. If you had done a CT head and a CT and not a CT angiogram and just did a carotid Doppler, you would be none the wiser and wouldn't have any idea that this had happened to him. His MRI was actually negative in this case. And we treated him actually with heparin in this case, and clot dissolved, and he was fine. So seeing people emergently is key. A good history does matter, but vascular imaging matters probably even more. And sometimes you need to be pragmatic. And I would just say that just because your investigations are negative, that doesn't mean to say your history is irrelevant. History matters, and keep taking it. So I'll finish there. Thank you.
Thank you, Professor Coutts. And we have a lot of questions here. Now, we technically only have three minutes in the program, but I've been informed that we are able to go later if our speakers are able to stay on for a few minutes. I guess first I'm going to just check. Dr. Coutts, are you able to stay on for a few minutes longer?
I can stay for a few minutes longer, yep.
And Dr. Rothwell?
Yep, yeah, no, delighted.
Excellent. Okay, so let me just try and go through a few of these. We can't hit them all, unfortunately, but the first one is around atrial fibrillation. Maybe we'll go to Dr. Rothwell. When you said a cumulative 2 minutes of atrial fibrillation, did you mean combined multiple events or a single run of greater than 2 minutes?
Yeah, sorry, and I should have made that clear. That's the single longest event. So a lot of patients have cumulative 2 minutes with very short few second events, and they seem to be low risk. 2 minutes seems to be a good cut point for higher risk patients.
That's excellent, thank you. Dr. Coutts, there's a question about how you are defining minor stroke.
I mean, I think minor stroke to me is a stroke that when they present acutely, you're not really clinically thinking about thrombolysis, is kind of the essence. You have to use numbers though to make things easy in real life. So personally, I tend to use it as a kind of NIH 0 to 3, but that sort of doesn't get to the crux of the matter, which is that if you have an NIH of 2 and you have a field cut and you're 45 and you drive, that's not minor. So I struggle to sort of give you an answer. I just think about it as a spectrum with TIA on one end and a little bit of weakness on the other end. So I lump them together. I think the treatments are the same.
Thank you. And a related question. This one's capsular warning syndrome. So they're your classic little fluctuating one. When do you consider giving the TPA? We'll ask you both because you might have different opinions here. Dr. Rothwell.
Yeah, I mean, we don't, but I mean, Shelagh knows more about this than me. As you know, there's some fascinating data on the lack of effectiveness, perhaps, of antiplatelet treatment in these patients and the possible benefits of increasing their blood pressure. And as Shelagh says, certainly controlling the physiology, giving fluids and lying flat possibly makes sense. But we've not had many cases at all where we've used thrombolysis, but I think Shelagh probably has more experience.
I mean, I've done it. You know, we've admitted people, we've even given them aspirin, Plavix, they've got better in front of you, so you haven't thrombolized them, and then they keep doing it, and then at some point, if it doesn't get better, we have reset the clock because they've gone completely back to normal and have thrombolized them. The honest answer is I don't know if it works or not. I have a sense that whatever I do, 50% of them do well and 50% of them don't. So I don't know.
So thank you. We have a question on TIA and blood pressure management. So do you allow, in the context of a TIA, the blood pressure to go up for about 24 hours, or are you more aggressive? So this is just to be clear, someone whose symptoms have completely resolved. Dr. Rothwell?
Yeah, I used to be more aggressive than I am now, partly because we realized with doing all the monitoring work that there's an enormous amount of white coat hypertension after TIAs, and I think it's an incredibly anxiety-inducing experience for the patient. They're going to an ED, they're having an MRI scan, a scary thing. And there are a lot of patients whose blood pressure is 180 over 100 in the ED, but then at home it's 120 over 70. And so I've become a little bit keener to wait and see than I used to be in this particular situation.
Thank you, Dr. Coutts. This one's a perfect one for you. What are your thoughts about tenecteplase over alteplase?
I suspect that it will eventually win the battle. I think that tenecteplase, you know, I think we need more data to clearly prove that, but it is much more easy to use with a single bolus, much less costly in many parts of the world, including, and particularly if you include the nursing care for an infusion for an hour, it looks like there's better recanalization rates and lower hemorrhage. But I think we need more data before we finally say the battle's been won.
Excellent. And Dr. Coutts, a question directed to you about the practice in Calgary around dual antiplatelet therapy for a minor stroke in the context of a carotid stenosis awaiting revascularization, given these patients were excluded from point. Do you guys routinely give the dual prior to ENDART?
Well, our surgeons don't like to operate on dual antiplatelet therapy. And so the practical answer is we try not to. As I said, we often will give a loading dose in the emergency department as we're figuring out what to do. I'm not a surgeon, so, I'm not going to decide what I think the technical risks are with that particular surgical patient. And so we need to have that discussion as a team. And so, yeah, I will often give dual overnight the first night, and then if they're going to get stented, they'll stay on dual. If they're going to have an ENDART, we'll stop the Plavix and take it from there.
Thank you. Now we know your thoughts, Dr. Coutts, on statins and stroke. Dr. Rothwell, what about high dose statins if you believe this is a cardioembolic stroke? What are your thoughts on that?
Yeah, it's a difficult issue, and we tend to have a sort of blanket rule of using statins in most patients unless there's a good reason not to. There's poor evidence, as you know, for lacuna strokes and arguably for cardioembolic events. But I think for most patients who are at high or increased vascular risk, they probably do benefit from a statin. And I think the history of medicine is mainly a history of doctors under-treating rather than over-treating. So I think we should probably use them.
Thank you. And a question to both of you, depending on your jurisdictions. How do you guys define elderly when you are talking about some of these trials in the elderly? Dr. Rothwell?
Yeah, well, that's changed now. I'm approaching 60. So I define elderly as anyone over about 80 or 90. But, I think it's biological rather than chronological, isn't it? There are some 90-year-olds who are still running marathons, and there are some 60-year-olds who wouldn't stand a haircut. So I think it's difficult to be chronological about it.
And Dr. Coutts?
Yeah, I agree with Peter. I think that obviously the trials define it by age. Some of them are 70 and things, but I think there are clearly 60-year-olds that you look at and they're incredibly frail. And, they're biologically much older than that. And that's one of the reasons our surgeons with COVID initially tried to do telephone assessments of people and then realized that you can't do that over the telephone and you need to physically look at somebody. And so, I'm sure Oxford is full of super grannies. So, that biologically is different than other parts of the world. Yeah.
And two antiplatelet questions here. Number one, if you have a patient with thrombocytopenia and they come in with a TIA, what is the antiplatelet approach there, Dr. Rothwell?
Yeah, it's a good question, and I think you do that in combination with your hematologists. I think one of the problems with thrombocytopenia is whether there's a qualitative platelet problem as well as a quantitative one, but as we all know, your platelets have to drop to 20, really 10 or 20, in order to really have a bleeding problem. And so if you've got enough platelets to cause a TIA or stroke, then I think it's, as long as the hematologists don't actively disagree, then you still need to use antiplatelet drugs in most cases.
Thank you. Dr. Coutts, let's say the same patient has platelets of 60 when they come in with an acute event. Would you go single or dual antiplatelet?
The answer is, of course, it depends. I wouldn't have trouble with giving aspirin with a platelets of 60. Whether I give Plavix as well would really depend on how high risk I thought they were. I mean, if the vessels were completely clear and I was suspicious it was AFib, I might just hold off and do single and look for the AFib at that moment. So it really depends on the patient.
So here's an interesting conversation about this Plavix resistance that everyone talks about. So you get a patient, they go on dual antiplatelet therapy for their 2 to 3 weeks. Then afterwards, you're going to downgrade to a single. Do you have concerns around Plavix resistance, and does that influence you on what you pick afterwards? Let's say the patient came in on aspirin when they had their TIA. Dr. Rothwell?
Genetic Plavix resistance is relatively unusual in our patient population, so we don't screen for it. I think the idea of changing the antiplatelet drug in someone that fails on one is probably a good idea. As you know, we don't have good trial evidence for that. But if you look at the subgroup analyses in those trials where you can get a sense of change the drug versus keep on the same drug, change the drug always seems to look a bit better. We certainly don't screen for Plavix resistance in the UK.
And Dr. Coutts, similar feeling or different?
No, similar. We also don't have a high sort of resistance in our population either. Although interestingly, I just had a patient that had carotid stenosis that I spoke to as a telephone assessment as part of COVID that somehow got to clinic rather than got referred to us directly in Emerge. And I put them on aspirin Plavix, and then they still had a further event the day they saw the interventionalist. And they switched them to ticagrelor as they were worried that they were Plavix resistant. We don't test for it though. The patient was Chinese, and so there was a higher risk.
And we're approaching, I think, the limit here. So let me just ask one last one. Both of you, around the Thales trial, so the ticagrelor, has that influenced your acute management at all? Dr. Rothwell?
It hasn't for us. I think it'd be great to see a head-to-head comparison of ticagrelor versus aspirin plus clopidogrel, and that is in the pipeline, but we haven't changed so far.
What about yourself, Dr. Coutts? Let me shift it a little bit and say the patient comes in with an acute event on Plavix.
Yeah, so it for the most part, it hasn't changed our practice, but it is there as a backup option in that particular sort of patient that has some large artery disease that's not going to be managed with any intervention. Sometimes we'll change them to aspirin and ticagrelor, but it's not that often. Yeah.
Thank you. So we have over 50 questions here. So unfortunately, as you can all imagine, there's no way that we can get to all of them. And we've already taken quite a bit of time from two very high profile professors and leaders in the field. So I want to thank the audience for that and for their understanding. And of course, I want to thank the speakers. I do look forward to the day where we will have the live conferences, and I urge all of you to please mob these speakers as they try and leave the podium and stop them from getting to the next room. We love that. But I'm going to then hand this back to Alina. Thank you very much for your attendance.
Thank you. For me, it's just left to say big thank you, and finally an announcement of our next webinar, which will be on the 25th of May, and will focus on simulation training, COVID and beyond. We'll have another really good speaker from Canada, Human Khosravani, and Paola Santalucia from Italy. So I think this will be another really interesting session. And I'm looking forward to seeing many of you there as well. So thank you, and have a nice afternoon and evening or morning. See you next time.